Our first presenter is Dr. Rodolfo Cucciani from Buenos Aires.
Good morning. My name is Dr. Cucciani. I'm from Buenos Aires, Argentina. No disclosures. The purpose of this presentation is try to find out the best technique in each step of the lipotransfer process. We attend at many meetings and workshops where everybody says their results were the best, whatever the technique they use. So what's the correct technique? There are two trends in lipotransfers. The one that says that the infiltrated graft disappears and new fat is generated from stem cells, so fat preparation process is not important. And the other trend says that part of the infiltrated fat remains, so fat preparation is really important. We present 60 patients. We measured negative vacuum pressure between different syringes using a manometer and fat viability with a reagent called MTT that measures mitochondrial activity. Most actual papers for fat transfer studies are based on viability because direct vision techniques are unreliable. The results were about vacuum pressure, syringe size is important. A 5 cc syringe at maximum vacuum produces practically no damage to fat cells because vacuum is about 300 millimeters of mercury. A 10 cc syringe at maximum vacuum produces more fat cell damage, and using a 60 cc syringe, negative pressure will be almost 1 atmosphere and high fat cell damage. So vacuum is important, really. We make some comparisons with decantation as a control. First, with MTT, we compare decantation and centrifugation techniques, analyzing the centrifuged middle fat. We measured this middle fat and observed how viability decreased when RPMs get higher. So it seems there's a problem between centrifugation and fat cells viability. Then we compared sieving and washing techniques. And although viability was lower in sieving, the difference was not very important. But the winner is the washing technique in the whole processing stage, always comparing us with decantation as control. What about transfer between syringes? We decided to evaluate two patterns, one between 60 cc and 10 cc syringes, and the other one between 20 cc and 5 cc syringes. There were no important differences between them, although of course viability was lower between 60 and 10 cc, probably because of fat trauma. We also observed that patients with high body mass index have larger fat cell size, and we think this could alter cell fragility because larger cells are more prone to break. And we confirmed what we supposed because fat samples from patients with high BMI show low viability in decantation inclusive. As you can see, the higher the BMI, the higher the viability reduction we found. We also checked what happened with local anesthetics and viability in a specified proportion. That is, 1 cc lidocaine in 9 cc of fat in a 10 cc syringe, especially with xylocaine, 2%, and we found a great viability diminution. So local anesthetics could harm fat grafts. And what about oxygen? The more fat samples are exposed to air, the lower the viability we found. Perhaps closed techniques are better. Stem cells, we culture and enrich them. This is the way for stem cells isolation. And this chart is very important because in the first group, in yellow, we obtain a fat sample as always. Then we isolate them in two groups, adipocytes and stem cells, and a fourth group joining stem cells and the fat sample. And we obtained an enriched group. And we can see how the viability increases. But after 1 week of culture, We observed how the enriched group increases much more, about 60%. So perhaps we have to enrich. This is a picture of a stem cells, a pre-adipocyte, compared to a pre-adipocyte. And we can see the lipid drops in orange because of oiled red dye. So our conclusion is that perhaps we must enrich. After the papers from Yoshimura and his cell-assisted lipotransfer, for obtaining enriched fat, we should need a cell separator and collagenase that costs a lot of money and time. So how can we enrich? A few minutes ago, we said centrifugation damages adipocytes at high RPMs, but perhaps this is the only way to obtain a pellet where we can find stem cells in the operating room. But are there stem cells in this pellet? Yes, there are stem cells, and we confirmed it by using these cell surface markers measured by flow cytometry. Okay. And also we observed that centrifugation does not damage stem cells, as we can see here after counting them. So we really can use this pellet for obtaining stem cells. Of course, the quantity of stem cells are smaller than those obtained using a cell separator. This is the way we proposed to enrich. Part of the fat graft is washed, and another one is centrifuged at 3000 RPM for 5 minutes, where we obtain a pellet that we use to enrich the washed group. Okay. For ending, this is what we call the way for a successful lipotransfer before injection. Low vacuum harvesting, processing, the winner is washing, syringe transfer between similar sized syringes, avoid high BMI fat samples, use diluted local anesthetics, avoid air exposure, and stem cells enrichment. Thank you.
Okay. Great talk. I have a question for Rodolfo. So you gave a nice summary of what you propose for harvesting fat, treating the fat, introducing the fat, but I would say the majority of the fat that we do is facial and buttock and breast. How should we plan to do the technique differently for those two different areas? Because some require small syringe introduction, and some you prefer to use larger syringes, like maybe a 60 cc syringe for the buttock. To take 5 cc syringes in the buttock would probably take people all day. And is that a good way to do it? And how would you recommend for these two different areas?
So you are asking how to obtain larger volumes?
Larger volumes and processing it properly so that you get the highest maximal survival in those different areas. Why, because it seems like it's a little contradictory in some of the things you're saying in terms of how most people probably handle it in the real world.
Yes. The problem is about vacuum, because vacuum damages fat samples. So if you use a syringe, for example, of 60 cc's that perhaps you use in buttocks, at maximum vacuum, it's just almost 1 atmosphere, so you destroy the fat cells. The only way is to use smaller syringes without destroying them, and perhaps you can use decantation also to reduce time, but decantation has a lot of contaminants debris that damage or compete with stem cells and with fat cells to be captured when you injected them in the body. So the best way is, the only way I know, is to use smaller syringes with perhaps more people and a smaller vacuum.
Okay, that's, I guess, all we have for right now.